Welcome everyone and thank you for joining me for today's presentation. The title of this talk is Wolf in Sheep's Clothing, the Gender Exploratory Model as a Subtle Form of Conversion Practices. In this session, I'll be discussing how Gender Exploratory Therapy, or GET, presents itself as a neutral, supportive approach to understanding gender identity, but in reality, it functions much like the conversion practices that have harmed countless trans people. Conversion practices are not always overt and can be subtle, seemingly well-intentioned, but ultimately reinforce cis-normative ideals by casting doubt on trans identities. By the end of this talk, you'll see why we must recognize GET as a form of conversion practice, despite its claims of neutrality and care. Before we delve into the practice itself, let's establish some context around gender exploratory therapy. GET is an alternative therapeutic approach to gender-affirming care developed by a group of clinicians who formed the Gender Exploratory Therapy Association in 2021, now rebranded as Therapy First. Key figures behind GET have affiliations with groups like the Society for Evidence-Based Gender Medicine and GenSpect, organizations identified by the Southern Poverty Law Center as part of an anti-LGBT pseudoscience network. These organizations actively oppose gender-affirming care, framing it as driven by a political agenda rather than evidence. To build on the background context, I want to briefly show this anti-trans conversion therapy map of influence, developed by Lee Lavelle from Health Liberation Now. This map visually represents the extensive network of groups and clinical affiliates involved in promoting so-called gender exploratory therapy. The map includes 15 major groups, organizations, and projects like the Society for Evidence-Based Gender Medicine, GenSpect, the GET Association, along with their international affiliates, highlighting the global scope of influence that these groups have in promoting conversion practices and strategically advance anti-trans narratives, spreading disinformation and misinformation. This tool is an invaluable resource for anyone looking to understand the coordinated, pseudoscientific push against trans-affirming care worldwide. It's accessible online, and I highly recommend taking the time if you're interested in understanding the global landscape of anti-trans conversion practices. Go check out the website thatweirdolee.github.io. According to Lavelle, and I quote, GETA, a new therapy association built specifically to promote gender exploratory therapy, demonstrated exponential growth within the first few months of operation. The organization was announced on December 5, 2021, with only 2 known affiliates, Sasha Ayad and Stella O'Malley. In just 3 months, they gained additional team members, as well as an ever-expanding directory that includes several individuals involved in other named groups. This explosion of growth demonstrates the expansion of a new market of targeted conversion practices. At the same time, their official accounts have promoted events by other identified members who campaigned against the Government Equalities Office consultation on banning conversion in the United Kingdom. In doing so, this puts trans, detrans, and gender diverse people, the group's established clientele, of all ages at risk of conversion practices for gender identity and expression. Though there is a particular danger to youth and young people up to the age of 25 as a result of the group's targeted advertising. In 2023, the Gender Exploratory Therapy Association rebranded itself as Therapy First. Their public statement on this rebrand emphasizes a shift towards psychotherapy as the first-line intervention, likely an effort to distance themselves from growing associations with conversion practices. By positioning psychotherapy above gender-affirming care, Therapy First relies on a logical fallacy, specifically the straw man fallacy. By mischaracterizing gender-affirming care as a rushed, one-size-fits-all approach that overlooks individual needs, in fact, psychotherapy is a core component of gender-affirming care, which also includes social support and a holistic approach that allows exploration while honoring a young person's right to self-determination. This approach is not patronizing. Rather, it empowers young people to make informed, developmentally appropriate decisions with the guidance of healthcare providers and the support of their families. Despite this rebranding, Therapy First's affiliations remain closely tied to other anti-trans groups who have extended their influence to policy, petitioning to restrict puberty blockers, and opposing protections for gender identity, framing affirming care as risky. In contrast, the Substance Abuse and Mental Health Services Administration in the US warns against non-affirmative practices like GET, stating that approaches discouraging youth from exploring and expressing their gender identity can have long-lasting, harmful impacts. To further illustrate the scope of anti-LGBTQIA+ pseudoscience, I'll briefly introduce the Southern Poverty Law Center's Captain Project. The Captain Project traces how pseudoscientific frameworks are strategically used to oppose gender-affirming care, precisely the stance taken by Therapy First and its affiliated organizations. Captain's chapters highlight tactics that align closely with Therapy First's methods. For example, Chapter 1 explores how anti-trans healthcare rhetoric aligns with agendas from the Christian right and even white supremacist ideologies. Chapter 3 delves into the deliberate spread of anti-trans disinformation to divide LGBTQIA+ communities. Chapter 4 reveals how research is selectively misrepresented to argue that affirming care harms youth. This tactic is directly mirrored in Therapy First's communications, which highlight potential risks of medical transition while downplaying evidence that supports its benefits. Finally, Chapter 5 outlines the vast network of over 60 organizations working in concert to advance anti-LGBTQIA+ policies. Therapy First, Society for Evidence-Based Medicine, and GenSpect are prominent nodes within this network, promoting conversion practices under scientific guise. Take the Society for Evidence-Based Medicine, or Gender-Based Medicine, for example, which misrepresents itself as an objective, research-driven organization by misleadingly using evidence-based in its name to lend credibility to anti-trans agenda. On the Law Center's website, you can download fact sheets, resources, such as the Conversion Therapy Fact Over Fiction. The Captain Project sheds light on how pseudoscience is weaponized to create public fear and influence restrictive policies. Therapy First, as part of this network, exemplifies these tactics by framing gender diversity as a pathology needing correction rather than a valid experience. Therapy First, previously known as Gender Exploratory Therapy Association, is a global network of over 300 mental health providers, including South Africans, committed to making psychotherapy the primary intervention for gender dysphoria. Unlike organizations that genuinely support gender diversity, Therapy First openly rejects gender affirmative care, positioning it as oversimplified and politicized. They frame affirmation as inherently risky, instead promoting an open-ended, non-affirmative approach to managing gender distress. Therapy First claims to support client autonomy and ethical care, yet advocates against timely access to affirming interventions for minors. They argue that young people may not fully grasp the implications of transition and insist that identity must be explored in depth, often indefinitely, to uncover potential influences like trauma or social pressure. This perspective implies that being cisgender is a stable and preferred outcome, embedding subtle but firm cis supremacist ideals within their approach. Interestingly, Therapy First includes a trans man on their board. While this might appear inclusive, it can serve as a misleading endorsement, suggesting they truly support trans experiences while promoting ideologies that prioritize cisgender identities. As Andrea James from Transgender Map notes, Therapy First effectively functions as a network of therapists who oppose informed consent for trans healthcare. While they are loud in their opposition to affirmative care, their cis supremacist assumptions that cisgender outcomes are preferable remain more covert. So what exactly is gender exploratory therapy? On the surface, GET is presented as a reflective, patient-centered process meant to help young people explore their gender identity thoroughly and without rushing to any particular outcome like transitioning. This approach claims to offer support to individuals by focusing on a broad biopsychosocial perspective. The guide describes this as an in-depth process that looks at all aspects of a person's life, stating that exploratory therapy seeks to explore not just the person's gendered experience, but the entire landscape of their current life and lived experience. While this thorough approach may appear supportive, it often leaves individuals in a prolonged state of questioning, subtly and persistently reinforcing doubt about one's trans identity. According to their clinical guide, Gender Exploratory Therapy aims to help individuals understand and address the multiple intersecting factors generating distress in their lives. They outline 8 points. Number 1, open to a range of outcomes. GET claims it is open to any conclusion the young person might reach about their gender, whether they come to identify with their sex assigned at birth, find non-medical ways to manage gender-related distress, or ultimately decide to pursue transition. The guide frames these options as equally valid, emphasizing the importance of exploring each thoroughly before deciding on a path forward. 2, a contextual understanding of gender dysphoria. GET holds that gender dysphoria should be understood within the individual's developmental, social, familial, and relational context. The therapy seeks to explore not just the person's experience of gender, but their broader life circumstances, asking how they came to develop distress around their assigned sex. 3, it's a developmentally informed approach. The guide asserts that gender dysphoria in young people often coincides with key developmental stages such as separation, individuation, and identity formation. GET seeks to understand how these developmental struggles might intersect with gender distress, encouraging clinicians to consider how the family system and broader environment may impact the young person's sense of self. 4, addressing comorbid conditions. GET aims to integrate the treatment of other conditions that frequently co-occur with gender dysphoria, such as anxiety, depression, autism, and ADHD. The guideline emphasizes a comprehensive, whole-person approach to treatment, asserting that viewing gender dysphoria in isolation is reductionistic. 5, acknowledging the interplay of sexual and gender identity development. GET argues that anxiety and conflict about emerging adult sexuality can contribute to gender distress. This approach seeks to distinguish between gender and sexual identity development, while also acknowledging their potential influence on each other, especially when young people experience shame around same-sex attraction. 6, it's a long-term process. The framework emphasizes that GET should be a prolonged, regular engagement allowing for thorough exploration over time. The guide stresses that the complexities in the lives of young people with gender dysphoria require an extended process to identify, understand, and address these issues. 7, an evidence-based approach to suicidality. The manual addresses the perceived risk of suicidality, stating that suicide risk in gender-questioning youth is comparable to that in any other mental health condition. It suggests that managing suicidality as it would be in any mental health context and emphasizes that there's little evidence that transitioning reduces suicide risk long-term. And 8, true informed consent. Finally, the guide underscores true informed consent, which it describes as necessitating self-awareness and understanding of unconscious motivations. It encourages clinicians to have honest discussions about the state of research and the risks and benefits of transition. In this context, exploratory therapy is positioned as a space for both informed decision-making and deep self-reflection. So, according to the GET guide, it is about creating a reflective space for young people to understand their gender identity within a broader life context, without affirming any specific outcome. Now, let's look at how the GET manual distinguishes itself from other therapeutic approaches, specifically stating what it is not. 1, it is not conversion therapy. GET explicitly states that it is not conversion therapy, which traditionally refers to treatments aimed at changing sexual orientation. They acknowledge that conversion practices have no place in healthcare. Instead, GET is positioned as a non-invasive exploration of gender-related distress without aiming for any fixed outcome, whether that's a cisgender or trans identity. The guide asserts that GET respects individuals' freedom to express themselves authentically, and that its goal is not to produce a normative cisgender identification. 2. It does not assume that trans identification is universally adaptive. GET recognizes that while a trans identity can bring freedom, autonomy, and authenticity for some, it may not be beneficial for everyone. The manual suggests that for certain individuals, identifying as trans might be a response to psychological pain rather than a true expression of self. 3. It does not assume gender-affirming interventions are universally helpful. The manual challenges the notion of the affirmative approach as the gold standard for treating gender dysphoria. It argues that the evidence supporting gender-affirming care is not robust enough to justify a universal approach. Instead, GET claims to take a more individualized view, suggesting that while affirmation might benefit some, it could potentially be unhelpful or even harmful for others. And 4, it does not encourage obfuscation of biological facts. Finally, GET's approach includes an emphasis on what it refers to as biological realities. They address concerns that some young people may believe medical or surgical interventions will fully transform them into the opposite sex. GET promotes what it calls an age-appropriate discussion of biological facts alongside the exploration of gender. In this way, it seeks to balance the identity exploration within the discussions on the reality of biology and disentangle this from gender role stereotypes. So, wait, it's not conversion therapy? The Trevor Project even flagged the launch of their clinical guide on YouTube as conversion therapy. Okay, so what is conversion therapy for trans youth specifically? If GET claims not to be conversion therapy, it is essential to define what we mean by conversion practices, especially as they apply to trans and gender diverse youth. Conversion practices aim to alter or suppress an individual's gender identity, often to align with cisnormative and cisgenderist ideals. Here's how this could play out. 1. Pathologizing gender diversity. Conversion practices often frame trans identities as inherently disordered, unstable, or the result of trauma, peer influence, or external pressures rather than a valid self-experienced identity. This approach suggests that being trans is a problem to be solved rather than an authentic experience of identity. By framing gender diversity as something that needs fixing or exploration rather than affirmation, these practices cast doubt on the legitimacy of the youth's identity. 2. Gatekeeping access to affirming care. Conversion practices frequently manifest through delaying or denying gender-affirming care. This gatekeeping is often framed as a caring or cautious approach, but it can have the effect of wearing down the individual's resolve and self-trust, subtly pushing them away from their gender identity. And 3, promoting cisnormative and cisgenderist outcomes. Finally, conversion practices often lead young people toward desistance or non-affirmation, even if this outcome is not explicitly stated. By emphasizing neutrality and exploration, practitioners can steer individuals back toward their birth-assigned gender, framing cisgender outcomes as more stable, natural, or preferable. By pathologizing gender diversity, controlling access to gender-affirming care, and subtly promoting cisnormative outcomes, these practices create environments that erode self-confidence in youth and undermine their journey toward authentic self-acceptance. To understand gender exploratory therapy and how it aligns with conversion practices, we need to unpack two key concepts: cisnormativity and cisgenderism. These terms help explain the framework in which conversion practices operate and the biases they reinforce. Cisnormativity is the assumption that everyone is or should be cisgender. That is, that their gender identity aligns with their sex assigned at birth. This is the default or normal expectation in society. Cisnormativity creates an environment where cisgender identities are not just seen as typical, but as the correct or preferable state. When it comes to practices like GET, cisnormativity shows up in the way that non-cis identities are subtly and sometimes overtly framed as deviations or uncertainties that need exploring, questioning, or even fixing. Cisgenderism goes a step further by actively positioning cisgender identities as superior to or more valid than trans identities. It doesn't just assume cisgender is the norm, it actively enforces cisgender as the goal. In the context of GET, cisgenderism can appear in how the therapy encourages individuals to question and delay their trans identities, while rarely, if ever, suggesting the same level of scrutiny for cisgender identities. This reinforces the idea that being cisgender is stable, desirable, or even the healthiest outcome, while trans identities are seen as suspect or the result of underlying issues. Okay, so let's go back to the clinical guide itself to see how GET conceptualizes gender dysphoria and the therapeutic approach they recommend. According to GET's guide, one of the primary goals of exploratory therapy is to help young people understand the nature of their distress from a broader, nuanced perspective. The manual suggests that adolescents may fixate on transition as the sole solution to their distress. GET positions psychotherapy as the way to help them view their gender distress within a wider context, exploring aspects of experience that might be outside of their immediate awareness or even actively disavowed. In the guide, GET also underscores the idea that adolescents today live in an environment that, in their words, supports and reinforces trans identification. The manual emphasizes the impact of social influences on young people, suggesting that these factors are crucial to consider in the therapeutic process. The message here is that social and environmental factors may be contributing to what the youth interprets as gender dysphoria. The guide also presents gender identity not as a fixed core aspect of self, but as something that is heavily influenced by historical, relational, and socio-political factors. It describes gender as an emergent phenomenon arising from multiple intersecting systems like family, society, and individual development. This perspective on gender dysphoria, they claim, stands in opposition to the gender-affirming model, which GET critiques for reifying gender identity, treating it as an innate characteristic akin to physical traits like hair color or handedness. Another layer in this framework involves GET's focus on what they call the true self versus the false self. Citing foundational thinkers in psychotherapy like Lang, Sullivan, and Winnicott, the manual describes the false self as a protective layer that shields the individual's authentic self from potential threats. The guide suggests that young people with gender dysphoria might be adopting a trans identity as a way to shield or hide their true self, rather than as an expression of it. The manual presents a series of complex questions. Does a trans identity liberate the true self, or does it create a new false self? Is it an attempt to find a voice or a new way of hiding? This line of questioning subtly casts doubt on the authenticity of the individual's trans identity, framing it as potentially a response to underlying self-hatred or psychological distress rather than an expression of who they truly are. Overall, these ideas form the foundation of GET's approach to probe, question, and scrutinize whether trans identification is genuinely the true self or possibly a response to deeper unresolved issues. The clinical guide contains a couple of case studies. So let's have a look at the case study that follows Elliot. A 13-year-old initially identifying as a trans boy whose journey explores various dimensions of gender, family dynamics, and personal identity. The guide refuses to use Elliot's chosen name. Remember, they don't want to affirm the so-called false self or the potential false self, and believe that social transitioning and using the person's correct pronouns and name starts them on a slippery slope to bottom surgery. Case background. Elliot, described as a bright and socially conscious young person, began identifying as trans after joining their school's Gender and Sexuality Alliance. This is according to the guide. Their parents initially weren't aware of the shift until their mother discovered Elliot's chosen name in text messages. This case highlights not only Elliot's internal struggle, but also the impact of family dynamics on their identity journey. Elliot's family includes an older brother with chronic medical issues, which has created a certain level of family strain and a complex relationship between Elliot, their mother, and their more distant father. The case emphasized a multifaceted, open-ended exploration of their gender identity. Therapy sessions included both parents, aiming to adjust parenting roles to support Elliot's independence while maintaining family boundaries. The parents worked on distributing roles, balancing discipline with support, ensuring each parent engaged with Elliot on a personal level. For instance, their mother was encouraged to connect with Elliot through enjoyable activities that did not center around gender discussion. The therapist focused on how Elliot's gender identity evolved within their social environment, particularly through their involvement with the GSA. Therapy aimed to support Elliot's sense of self while encouraging reflection on whether their identity as Elliot was truly aligned with their true self, or possibly a protective response to underlying needs or social pressures. The case study describes moments where Elliot struggled with assertiveness, particularly in expressing their needs at home. Therapy supported them in developing a confident voice and helped their parents see the value of listening to Elliot's perspective, even when their views differed from theirs. Over 4 years, therapy with Elliot led to several key outcomes as described in the guide. The focus on broad exploration rather than immediate transition allowed Elliot's fixation on gender labels to soften. They began using a nickname L and adopted a more fluid view of gender. By the time they applied to university, they selected prefer not to say for gender, indicating a less rigid attachment to specific identity labels. Here we see an example of the therapist's approach to names and pronouns, which plays a significant role in the GET framework. Rather than using Elliot's chosen name, the therapist introduced alternatives like M or E, a tactic described as setting non-inflammatory protocols around pronouns and names. When GET positions itself as against the gender-affirming approach, it is not only referring to medical interventions, but also changes in pronouns, names, and appearance. The therapist also raises concerns about Elliot's ability to understand the grand assertions they made about wanting medical transition. Phrasing like incapable of fully comprehending and the fantasy of transitioning suggests a pathologizing view. By framing Elliot's wishes as unrealistic and their stance as a defended position, the therapy subtly questions the validity of their identity. This method not only delays social affirmation, but can also undermine Elliot's self-confidence and sense of self, reinforcing doubt and planting seeds of uncertainty around their choices. This approach actually hinders true exploration, as Elliot is not allowed to try out and see what fits in a supportive environment that really isn't attached to any particular outcome. Elliot would not have to prove something or fight for recognition and commit to a specific outcome. In this introductory session, we see subtle yet clear gatekeeping methods at work. Rather than acknowledging Elliot's identity, the therapist frames Elliot and Emma as two distinct characters in Elliot's life, implying that both identities need to be examined and explored as if they hold equal weight. This perspective subtly questions the legitimacy of Elliot's trans identity, suggesting that it may only be one of the many roles they inhabit rather than an authentic self-discovery. By stating we're going to talk about who Elliot is and who Emma is, the therapist introduces a layer of doubt, framing Elliot's trans identity as something to be analyzed, split off from, an alter ego of sorts. This form of manipulation is a far cry from patient-centered care. Elliot's long and winding road to nowhere, or their long walk to prefer not to say. Throughout this period, the therapist maintained an ongoing exploration of Elliot's identity. Dialogue shifted from exploring Elliot's role as a leader in their school's GSA to questioning their beliefs around transition and so-called reality testing their hopes and fantasies about medical interventions. Elliot experienced significant dysphoria around menstruation, a distress that could have been alleviated with puberty blockers. However, rather than supporting such interventions, the therapist continued challenging Elliot's understanding of their own identity, saying, "Transition can only change some things about your body, but it won't make you male." This remark elicited frustration from Elliot, who responded, "That's the same kind of bullshit my mother tells me." Over time, Elliot's identity journey was met with subtle challenges, such as being encouraged to re-evaluate their experiences through the therapist's lens, continually probing for doubts and alternative perspectives. We also see the development of themes around Elliot's family dynamics and desire for care, where they navigate relationships, particularly through the lens of longing for nurturance and support, as they process their identity in a complex, prolonged therapeutic setting. The lengthy process and constant exploration of every angle of Elliot's identity underscore how this approach not only effectively delayed their affirmation, but prohibited them from exploring their gender identity fully and authentically so that they could, in fact, make a more informed decision. Gender exploratory therapy, in reality, reinforces cisnormative standards by covertly steering clients away from exploring and affirming their trans identity. It positions exploration as inherently superior to affirmation, suggesting that being trans might stem from other factors like trauma, social influence, or confusion, rather than being a valid identity. This creates a therapeutic environment where cis identities are treated as the default, with trans identities needing justification. By framing prolonged examination as responsible, GET uses care language to mask gatekeeping practices, ultimately encouraging desistance while maintaining a guise of neutrality. In this way, GET manipulates trust, creating a false sense of support that leads individuals to believe they are being genuinely supported, helped, when in fact, their identity is systematically invalidated. The subtle but persistent doubt embedded in GET has significant mental health consequences, especially for trans young people. It leaves individuals in a prolonged state of self-doubt, shame, and internal conflict, which can lead to serious emotional distress. For many trans youth, this approach increases the risk of depression, anxiety, and even suicidality. The constant questioning of their identity can foster feelings of isolation and hopelessness, making it difficult for them to embrace who they are. Furthermore, GET's emphasis on exploration over affirmation can lead to internalized transphobia, where the individual begins to distrust their own experience and seek validation externally. The harm caused by keeping individuals in limbo is not just emotional. It has real, long-term mental health impacts, delaying the support that they need to thrive. This is the insidious nature of GET. It presents itself as protective, but the cost is the mental health and well-being of trans and gender diverse young people. Healthcare providers play a crucial role in supporting trans individuals, especially young people, through affirming and evidence-based care. To effectively combat conversion practices like GET, it's essential to understand how covert forms of cisnormative ideology can infiltrate therapeutic practices. We have an ethical responsibility. As healthcare providers, it is our duty to recognize and reject conversion practices, including subtle forms like GET. They may seem benign, but ultimately they harm our clients. We must be vigilant in recognizing and rejecting these practices. We need to engage in self-reflection and identify internal biases. Recognize and address assumptions such as viewing cisgender identity as the default or stable identity. Ask yourself if you're questioning trans identities more than cis identities. These beliefs can unconsciously steer clients away from self-acceptance. And we need to challenge the misrepresentation of gender-affirming care. When we care for young people curious about their gender identity and experience, we support them in their journey to self-discovery by affirming their exploration, true exploration, not examination and manipulation. Contrary to claims that it is rushed or reckless, affirming care is conducted with caution and respect for each individual's unique journey. Gender-affirming care is evidence-based and uses considered, context-specific, informed consent model that supports long-term well-being. For youth experiencing gender dysphoria, puberty blockers can provide a safe, reversible option that allows time for exploration without committing to irreversible changes. Affirmative care that includes timely intervention reduces harm and greatly improves mental health outcomes, giving trans individuals the support they need to thrive. By committing to these principles, healthcare providers can actively protect against covert conversion practices, advocate for affirmative care, and ensure that all clients are supported in ways that respect their identity and self-determination. To wrap up, let's look back at the troubling agenda we've uncovered within Gender Exploratory Therapy and how it ultimately fails to support trans youth. GET's approach operates under the appearance of neutrality and exploration, but in reality, this model has significant mental health consequences. For some, this prolonged questioning and denial of care can even intensify risks of depression, anxiety, and suicidality, clearly contradicting its supposed concern for well-being. GET often positions gender dysphoria as a symptom of underlying trauma or psychological issues, subtly framing trans identities as maladaptive. It reinforces cisnormativity, heavily favoring non-trans explanations and encouraging desistance without ever explicitly saying so. While GET claims to focus on the whole person, in reality it prioritizes exploration as deflection, a tactic that effectively pressures individuals to reconsider their gender without open rejection. This approach erodes autonomy, casting doubt around trans identities and making clients feel they have to prove or defend their identities in therapy, rather than explore their identity. At its core, GET is therapist-guided, not patient-centered. It is manipulative and it fosters a culture of mistrust, imposing uncertainty and challenging self-determination while therapists maintain control over the course of care. It's fair to say that therapy first should be called therapist first, given how the model prioritizes the clinician's ideological beliefs over the actual needs of trans and gender diverse young people. Instead of upholding the principle of do no harm, therapy first's approach perpetuates harm by forcing young people into a therapeutic holding pattern where self-acceptance is continually delayed. In conclusion, healthcare providers and mental health practitioners must recognize the significant harms embedded in the so-called exploratory practices. We have an ethical responsibility to provide evidence-based, gender-affirming care that supports trans youth in ways that respects their autonomy, reduces harm, and improves mental health outcomes. True care means stepping beyond covert conversion practices and supporting exploration so we can build trust, not tear it down.